everybody. Hi everyone. I hope everyone is having a good day so far, a good Friday. Thank you all so much for joining today's Q&A session. My name is Rina Hisamatsu and I'm a registered dietitian. Let me share my screen in just a moment here. And we'll get started in just a few minutes while we wait for some of our other participants to join us. Alrighty, so I should be sharing my screen right now. Please let me know, either in the chat or just shout out if for any reason you're not able to see my screen. Alrighty, so we'll just give it another minute or two to let some others join, and then we'll get right into our presentation. Alrighty, so I think we can get going then. So hello everybody. Thank you so much for joining the Dietitian Q&A session today. My name is Rina Hisamatsu. I'm a registered dietitian at Domino's Farms Family Medicine, as well as the health educator for the Michigan Collaborative for Type 2 Diabetes. So today is session 3, and we'll be talking about fundamentals of meal planning. Before we get in, I wanted to just sort of give an overview of our topics for today. So we'll be doing a quick recap on what we discussed last week, or last month, my apologies, as well as going into a deep dive into some meal planning fundamentals. We'll be talking about some helpful tips to transition to a low carbohydrate lifestyle, going through some, managing any potential side effects, as well as we'll be ending our talk today with a short literature review on a study that was published in the last few years. All righty, so to start off, I first wanted to sort of follow up on what we had discussed in our previous Q&A session. And if some of you may remember, we talked about, strategies about utilizing motivational interviewing techniques to help identify patients, to help with the counseling approach, to really hone in on, individualization and sort of figuring out what are some strategies to help identify patients who may be suitable to pursue a low carbohydrate meal plan. So I wanted to hear from the audience today to see if any of you have had an opportunity to maybe counsel on the recommend the low carbohydrate lifestyle to any of your patients this past month. And if so, how did that go? What went well, and what were some of the struggles or challenges that you faced? So if anyone is willing to share their experience, please unmute or even put it in the chat. But maybe I'll give like 30 seconds or a minute for any of you to, if any of you want to share a highlight from this past month. All right, it seems like we have some shy folks today in the audience, but no worries. If we'll have some time for Q&A at the end. So if anyone wants to share their experience at that time, please do so. But hopefully everyone here has had a chance to use to recommend and counsel on low carb in the last few months. All righty, so let's get into the meat of things. Let's get into the meal planning fundamentals. So we know that, I know we, in the previous Q&A sessions, we sort of touched on what exactly the process of creating a balanced low carbohydrate meal plan. But I thought today maybe we can go into a deeper dive into those food groups and discuss more in detail on those the meal planning strategies. All right, so as you may recall, at MCT2D, we typically focus on two main pathways when it comes to the low carbohydrate meal plan. So the low carbohydrate meal plan is, as we know, is on a spectrum, but we typically have two pathways. So the very low carbohydrate meal plan is typically, we define that as being less than 50 grams of total carbohydrates a day. So for the very low carbohydrate meal plan, we generally recommend following a sort of a three-step process or a guideline. That includes picking a protein source, adding in non-starchy vegetables, and then complementing with some additional fats for satiety and flavor. On the other hand, the other pathway is the low carbohydrate meal plan. So the low carbohydrate meal plan is defined as a meal plan that stays within 50 to 130 grams of total carbohydrates a day. So similar to the very low carbohydrate meal plan, we follow the same three steps, but with the addition of the fourth step that has that room to incorporate some sources of complex carbohydrates. So let's go into the details of this technique in the next few slides. Here I just have another visual to sort of show you the plate method here using the 4 steps created by our lovely designer, Laria. So just wanted to show you basically the different types of foods that may be incorporated in each section of the plate. All right, so step 1, protein sources. As we know, protein is found in many different types of animal sources as well as plant-based sources. So that includes things such as fish and seafood, meat, poultry, eggs, dairy, as well as soy-based proteins like tofu and tempeh, and nuts, not nuts, seeds, beans, legumes, lentils. I do want to point out there that beans and lentils and legumes are starchier. Therefore, it's typically not recommended for individuals who are following a very low carbohydrate meal plan. It may be incorporated in some quantities on a low carbohydrate meal plan instead. So how much protein should I incorporate? In terms of estimating protein needs, currently there is no standardized protocol for the optimal protein intake on a low or very low carbohydrate meal plan. Although the RDA is set at 0.8 grams per kilogram of ideal body weight per day, generally on a low carbohydrate or very low carbohydrate meal plan, we typically aim for higher amounts of protein. Not only do proteins provide that additional calorie, they also provide the necessary amino acids for muscle growth, for repair, and they're an important structural component of tissues and cells. Typically for many practicing bodies, the protein intake of 1.2 to 2 grams per kilogram of ideal body weight is generally used, so in that reference range. And that has been shown to preserve muscle mass, improve body composition, as well as provide other benefits like satiety. So it's important to note that a low carbohydrate meal plan is not a high protein meal eating pattern. So it's typically does not go over the 2 grams per kilogram of ideal body weight. At MCT2D, we encourage a good place to start when it comes to protein intake is to start with 20 to 30, between 20 to 30 grams of protein per meal. That generally equates to about 4 to 5 ounces of protein in terms of weight. I always like to use sort of a visual when counseling. So typically in terms of protein amount, that's going to be, I like to use the hand portioning or the hand portioning method. So generally about 4 ounces is a bit bigger than the size of an individual's palm, about the thickness of a deck of cards. So that's a great place to start with patients. Now that can be adjusted, and the adjustments will be based on that individual's hunger and fullness cues, right? Are they still finding themselves very hungry shortly after their meals? Are they finding themselves too full after meals, or is it just right? And those adjustments may also be tweaked based on the individual's activity levels and their exercise as well. All right, so step 2 is going to be the non-starchy vegetables. As we know, non-starchy vegetables provide that welcome source of micronutrients. And there's a misperception that, low carbohydrate meal plans is all about meat and cheese. And oftentimes it's these non-starchy vegetables can be left behind. So we wanted to stress here the importance of incorporating an abundance of non-starchy vegetables with every meal. Not only do they provide micronutrients, they are a welcome source of dietary fiber as well. And we know that many of us are not able to reach the minimum recommendations for dietary fiber in a day. So non-starchy vegetables provide not only a great source of dietary fiber, but it aids in gut health and bowel regularity. And it also adds a lot of bulk to our meals too. So what you can see here, these are a few pages of a handout that we have created for one of the programs that we're working with in terms of recommendations for non-starchy vegetables. So look out for these handouts coming soon for MCT2D, and hopefully you'll find this useful to use with your patients during counseling. All right, now step 3 is adding fats. Now, we have a lot of different types and varieties of fats, as you can see here listed. We have plant-based fats from olives, avocados, nuts and seeds. We also have animal-based fats coming from dairy and cheeses and meats and other protein sources. So in terms of how much fats to add, similar to protein, we don't exactly have a protocol for how much to add. However, with that being said, when it comes to dietary fats, we want to utilize fats as a source of flavor and satiety. With that being said, there's a good place to start is by thinking about, okay, is there choosing 1 or 2 types of fats to include in your meal, and adjust based on hunger and satiety cues. We always want to encourage first choosing a protein source, making sure we have adequate protein, and then going with the non-starchy vegetables, and then adding fats on top of that for additional flavor and for satiety. So it's supposed to be used as a complement to a food, to help with making it more of a satisfying meal overall. We encourage choosing fats from whole food sources. So that includes both unsaturated and saturated fats from foods including meat, poultry, fish, cheeses, oils, butters, and plant-based sources like nuts and seeds. We typically also encourage, when possible, to choose unsaturated fats, because we do know that they have some additional benefits outside of the low carbohydrate meal plan. So that includes sources of unsaturated fats such as oily fish, nuts and seeds, olives, avocados, and such. The one thing that we encourage individuals to avoid are sources of artificial trans fats. So we know that trans fats occur naturally in some animal products to some small extent. However, artificial trans fats are oftentimes the fats that undergo partial hydrogenation or full hydrogenation, and they're found in a lot of processed packaged foods, including frozen pizzas, pie crusts, cookies, and cakes, which oftentimes are also high in carbohydrates too. All right. So step 4, so for individuals who are following a low carbohydrate meal plan, may have the option to incorporate some sources of carbohydrates coming from complex sources. Now, what we mean by that are examples include whole grains, starchy vegetables, legumes and beans, lentils, as well as fruit. Now, the quantities will depend largely on the individual's carbohydrate range. And the amounts can be adjusted based on what meal they're having, as long as it fits within their daily carbohydrate goal. And so this is where it becomes very useful to have a tracking tool or tracking resource to help them keep track of their, help them to tally up their carbohydrates throughout the day. All right, this is just another summary slide here, but I think I'll skip over to the next summary slide, showing the 4-step process. So again, step 1, picking a protein source. Step 2, adding non-starchy vegetables. Step 3, adding some fats. Step 4, this is the plus or minus if you're on a low carbohydrate meal plan, you may have the option to incorporate some sources of complex carbs. Now, we wanted to keep this as simple as possible for both providers and patients. So please let us know if you have any feedback on this process. All righty. So next, I wanted to touch on net carbohydrates. So net carbohydrates are defined as the non-fiber grams of carbohydrates contained in food. So we get asked a lot, whether or not we count net carbohydrates versus total carbohydrates. At MCT2D, we typically use the term, we use the concept of net carbohydrates for very low carbohydrate meal plans. So that is defined as less than 50 grams of total carbohydrates a day. This actually helps to encourage an abundance of foods that contain dietary fiber. So that includes things like non-starchy vegetables, nuts and seeds, and avocados. So the recommendation for net carbohydrates on a very low carbohydrate meal plan is generally 20 to 35 grams of net carbohydrates a day. All right, as you can see here from the nutrition facts label, just as an example, we would subtract the grams of dietary fiber from the grams of total carbohydrate. So that would be 33 in this case. Many practices will also, remove the grams of sugar alcohols from their net carbohydrate calculations. So because sugar alcohols are only partially digested, we recommend subtracting half of the grams of sugar alcohols from the total carbohydrate to find the net carb calculation. All righty. So a few helpful tips to transition to a low carbohydrate lifestyle. Particularly for individuals who are interested in pursuing a very low carbohydrate lifestyle, we encourage following a gradual transition to that lifestyle. So what that means is really transitioning one meal per week. And oftentimes this can help to ease or even completely avoid symptoms of keto flu, which is often experienced on a very low carbohydrate meal plan. So we'll discuss more about keto flu on the next slide. Another helpful tip is to check on our hunger. So can't stress this enough, but in a low carbohydrate lifestyle, we oftentimes encourage patients to really listen in, be more mindful about their hunger and fullness cues, because that can really help to determine whether or not any adjustments need to be made to their meals that day. So are they getting adequate protein? Do they need to tweak that just a little bit? Do they need to add more non-starchy vegetables? Or maybe it's some fats, maybe adding another sprinkling of nuts to a meal, or having a snack in between can be a helpful tool to help manage their energy and their hunger throughout the day. Fluid hydration is extremely important as well. In order to maintain electrolyte balance, as well as to offset the diuresis that's oftentimes caused by decreased insulin secretion or a reduced insulin dose if they're on some sort of therapy there. Careful monitoring should be made for sodium intake and fluid hydration for individuals who have a history of hypertension, heart failure, or CKD. All right, now consistency is also very helpful too. As we know, it's difficult to stay consistent, but on a low carbohydrate meal plan, consistency can be a really powerful tool to help patients see results and see progress when it comes to carbohydrate restriction. And of course, planning ahead. As we all know, this recommendation can be applied to all aspects of life, but truly planning ahead in terms of meal planning and planning meals for the week ahead can be a really great tool for success on the low carbohydrate meal plan. Alrighty, so next we're going to be talking about managing some potential side effects. So first and foremost, electrolyte imbalance. So as I mentioned earlier, this is known as the keto flu. It usually is made up of symptoms such as lightheadedness, fatigue, headache, and diarrhea. Typically, keto flu occurs at the very beginning of transition to a very low carbohydrate meal plan. Oftentimes, it's resolved on its own within the first week. However, the main intervention for keto flu is to make sure that it's treated with adequate fluid hydration and adequate sodium intake. Generally, that's going to be about 2 to 3 grams a day for sodium. And of course, that is if there are no underlying uncontrolled hypertension or heart failure for the individual. The next potential side effect is known as keto breath. Oftentimes, this is caused, again, this is something that individuals may experience on a very low carbohydrate meal plan, often due to the increase in ketone bodies. And so the way to intervene in this case is to make sure that, once again, we're maintaining proper fluid hydration, making sure to maintain good oral hygiene, and supplementing with sugarless mints or gums as needed. Muscle cramping is another potential side effect, and oftentimes magnesium supplementation can be a good solution to this. Typically 200 to 400 milligrams daily can do the trick. So constipation is a common side effect that we hear from a lot of patients pursuing a low carbohydrate lifestyle. Typically, first line of defense here would be to emphasize the importance of gradually increasing sources of dietary fiber coming from non-starchy vegetables and other sources such as nuts and seeds, and soluble fiber like flax meal, chia seeds, and even psyllium husk would be a good one. And of course, we need to make sure that that is balanced out together with fluid hydration. We can't forget to maintain hydration at the same time. If that strategy has not worked or if constipation is not resolved through this intervention, the next step would be to look into laxatives, stool softeners, or even identifying potential food triggers. So individualized counseling will be needed at this for this in order to identify potential food sensitivities that a patient might have, for example, dairy, cheeses, or nuts as well. All right, in some individuals, we may see an increase in LDL cholesterol. However, typically the increase in LDL occurs during the weight loss period and oftentimes is temporary. In this case, if an individual is seeing a rise in their LDL cholesterol, we would advise that they have a lipid recheck more regularly, every 3 to 6 months, and also to check after the patient's goals have been met and their weight has been stabilized. If it continues to be of concern, we may want to intervene with making some dietary changes. That includes reducing the intake of saturated fats. So foods such as fattier cuts of meat, processed meats, butter, cheese, and other dairy products, and focusing more on increasing intake of non-starchy vegetables, leaner protein sources, as well as unsaturated fats coming from avocados, olives, nuts, and seeds. Okay, last but not least, I always like to put in a reminder here that when it comes to the low carbohydrate lifestyle, there is no one size fits all, right? This is, it's a highly individualized process, and it's important to understand that we need to tailor this approach to each individual based on their experiences, based on their progress, and their needs. So the low carbohydrate counseling and low carbohydrate technique is going to require a lot of trialing, a lot of adapting and refining to help our patients achieve their goals. Alrighty, so next we're going to talk about, we're going to move into the literature review. So this is a little different from what I normally do for these sessions, but I thought this would be a good switch up. I wanted to talk today about a study that was published a few years ago in 2020. And this study looks at the impact of a very low carbohydrate meal plan on markers of risk for cardiovascular disease in patients with type 2 diabetes. And so I thought this was an interesting study to look at because we receive a lot of questions about concerns around LDL cholesterol. So this study was conducted by, in collaboration with Virta Health. Alrighty, so let's take a look at the background and the objective for the study. So there was a previous study that had found that the very low carbohydrate intervention that took place over the course of 2 years had created positive outcomes or improvements in body weight, in glycemic control, and multiple risk factors for cardiovascular disease, with the exception of an increase in the LDL cholesterol. So the objectives for this study, they wanted to investigate the impact of this intervention on markers of risk for atherosclerotic cardiovascular disease. All right, so the study design, this was an analysis of a non-randomized control trial, looking at the effects of carbohydrate restriction in a cohort of participants or patients with existing type 2 diabetes. So in terms of the intervention, they recruited participants who had an established diagnosis of type 2 diabetes with BMI greater than 25. Now they self-selected whether either to receive the 2-year continuous care intervention, which we call the CCI arm, or the usual care or the UC arm. In the intervention arm, participants received a meal plan that was less than 30 grams of total carbohydrates a day. They were consuming 1.5 grams per kg of their reference body weight in protein, and they were consuming fats to satiety. In the usual care arm, participants continued with their existing care team, and they received guidelines, nutrition recommendations from using the ADA guidelines. All right, in terms of data collection, labs were collected at baseline, at 1 year and 2 years. So some of the data collection included anthropometrics, such as BMI, weight, and height. DEXA scan was used in the CCI arm to measure total body composition. They conducted lipid analyses, lipoprotein analyses, and they also checked to see they ran a test known as the carotid intima media thickness, which is, it measures the extent of atherosclerotic vascular disease by measuring the thickness of the carotid artery. And they ran analysis using SPSS, is my understanding. All right, so some of the changes in primary clinical outcome measures. They found that there were no significant changes in the usual care group over time. So that includes lipids, lipoproteins, apoproteins, blood pressure, no changes in CIMT test, blood pressure were noticed in the UC group over time. In the intervention group, at 1 and 2 years, they found that the mean LDL cholesterol and HDL cholesterol increased, mean triglyceride and blood pressure decreased, total cholesterol remained unchanged, and they also had lower blood pressure, or they were also able to lower their blood pressure medications. In addition, their apolipoprotein A1, so ApoA1 increased. Now, ApoA1 is the primary protein component in HDL cholesterol. Remnant cholesterol remained decreased. CIMT, non-HDL, ApoB, which is the primary component, primary protein component in LDL, and the ratio between ApoB and ApoA1 remain unchanged after 2 years. Some additional changes in lipoprotein subfractions. So they found in the CCI intervention group, they found that there was a large increase in LDL, and there was an increase in large LDL compared to the usual care group. They also found that the small LDL decreased compared to the usual care group. There were no significant changes in HDL subfractions for either the continuous care arm or the usual care arm. All right, so the following 3 slides, so I sort of divided this graph into just 3 slides to make it larger, but this graph shows some changes in the particle diameter of major plasma LDL peaks. So there are 2 main LDL phenotypes that we typically research. So the LDL phenotype A is made up of larger, more buoyant LDL particles, while LDL phenotype B consists of more smaller and dense LDL particles. You can see pattern I, which is the intermediate phenotype, and that's often characterized by a broad distribution of intermediate sized particles. So this analysis here sort of looks at the changes in the LDL phenotype over the course of those 2 years. So at baseline, 1 year and 2 years. And I'm going to go slowly here, but you can sort of, if you take a look at the CCI arm, which is on the left-hand side, you can see that there is a change from phenotype B to phenotype A over the course of 2 years. So that's at 1 year, and that's at the 2nd year. So the results here show that there was a change in LDL subclass phenotype among the CCI participants. In the CCI, there was a shift in the LDL subclass phenotype from B to A. However, in the usual care arm, there was no significant difference. All right. So furthermore, they next looked at changes in lipoprotein subfractions and the CIMT in both LDL-C and ApoB, hypo and hyper responders. Excuse me. So they took a look at the CCI participants in the quartiles of greatest decrease and increase in LDL-C and in ApoB from baseline to 2 years. And they were categorized into hypo responders and hypo responders and hyper responders. What they found was that LDL-C hyper responders had significantly greater VLDL, small and medium, as well as IDL, compared to the hypo responders at 2 years. Oops. There was no significant decrease in the lipoprotein profile between ApoB for hypo and hyper responders at 2 years. And there was also no differences in the mean CIMT at 2 years between LDL-C and ApoB, hypo versus hyper responders. All right, so that was a lot to digest there, but some of the main takeaways that, that I was able to understand from the study is that there were changes in LDL subclass phenotype in the continuous care intervention compared to the usual care arm. So there was a a reduced level of small, dense LDL particles, and there was an increase in the large LDL particles. In addition, there was changes in the lipoprotein phenotype from B to A. There was also no significant change in total LDL particles in ApoB compared to the usual care arm. And thirdly, there was a significant increase in LDL-C in the continuous care arm, but it was primarily contributed to an increase in larger LDL particles or subfractions. So the results of this study, it demonstrated a sustained improvement of the atherogenic lipoprotein phenotype that's typically characteristic of type 2 diabetes, which usually it comprises of elevated plasma triglycerides, small dense LDL particles, and a reduction in HDL cholesterol. Now, as with all studies and research, there will always be strengths and limitations. So I think it's good to sort of highlight some of those here. So some of the strengths that the researchers discussed were that the 2-year duration, is a pretty significant amount of time that they were able to evaluate the lipoprotein changes in response to a very low carbohydrate meal plan. And the researchers were also able to track the serum beta hydroxybutyrate. So they were able to check the metric or the marker of nutritional ketosis and they were able to track that to study the shift in the LDL phenotype in relation to the nutritional ketosis frequency. Now, some of the limitations include, this was unfortunately not a randomized controlled trial. And like many nutrition-related studies, they were not able to have a tight control over food choices in both the usual care arm as well as the intervention arm. There was some lack of diversity in the population, which makes it very difficult for generalizability. And they were not able to determine any changes in the carotid intima media thickness test in both the UC or the intervention arm. All right. So that is the review for that study. And I hope you all enjoyed listening to this, and please let me know if, thank you so much for listening, but I'm going to now open the forum for Q&A and thoughts, discussions. If anyone wanted to discuss what I mentioned earlier, if they wanted to share their experiences, please do so. I think I see a couple of questions. So Mark, I think you raised your hand first.
Unmute. Can you hear me?
Yep, I can.
Any suggestions for how to get to lower the CIMT? If this study didn't show any change after 2 years, do statins or better blood pressure control or any other things that you've seen lower the CIMT?
That's a great question, Mark. I am not aware of any validated studies that provides recommendations for how else to, specifically for CIMT, improvement in CIMT test results. Definitely a good question, and I can look into that and perhaps provide some. I can look into the research and see if I can find anything.
Or has there been a study, or are there ongoing studies to see if this diet makes a change in the outcomes?
Yeah, that's a great question. So I believe actually Virta Health they are working on now a much longer study that's looking at a 5-year duration in terms of outcomes. So we're hoping to see more results in terms of more results, maybe changes in the CIMT results maybe further, 5-year reflections on LDL cholesterol to see if that has reverted back to normal after patients have reached their weight goals and their health goals too. So I would be very curious to see longer studies as well.
Thank you.
Absolutely. And I think Ankur, do you have your hand raised?
Yeah, thank you. So I appreciate that talk. In terms of pitfalls, there's sort of 3 major ones that I tend to run into issues when I'm trying to do low carbohydrate diets. And, our patients never just have diabetes. It's, they're tend to be complex and have other medical conditions. But the 3 that I run into issues are they have co-occurring, gout is a common one. They're on Coumadin. And then the 3rd one is irritable bowel syndrome. And it just gets really tricky in terms of the starches and just all these different recommendations. What's good for diabetes often can be bad for the other things. And so I don't know if there's any pearls. Obviously, if we have the resources or availability, we would try to get a dietitian referral, but that's usually not realistic for a lot of our patients. So just any thoughts you had on that?
Yeah, absolutely. I agree that, that those 3 challenges that you're facing makes it very hard for individuals to carry on with the low carbohydrate lifestyle long term. What I can say to that is, that's definitely very challenging and complex cases that you have brought up. Particularly when it comes to, I think you mentioned IBS as one of the challenges. When it comes to IBS, that's definitely a challenging scenario. I can speak to one experience that I have where I also had a patient who was experiencing IBS symptoms, and they were also on a low carbohydrate meal plan. And it was just difficult because a lot of the low carbohydrate alternatives, including things like cruciferous vegetables, cauliflower, are considered high FODMAP. So it was just a very challenging meal plan to combine both low FODMAP and low carb. I think it's about sort of meeting where the patients are at, sort of seeing, okay, what are the benefits that this individual is getting out of low carb? Are we seeing results in terms of, if this is a type 2 diabetic patient, are they seeing results in their blood sugar? Are they seeing improvements in A1C? If weight loss is a goal for them, are they seeing improvements there? And to sort of see, okay, maybe once they've reached their target goals, seeing if maybe then their meal plan can be tweaked to perhaps reintroduce some of those carbohydrates back in, or reduce in terms of gout. Are there some alternative protein sources where they can perhaps switch to more plant-based sources of protein, which would of course increase their daily carbohydrate intake. So really, I think it's going to be on an individual basis to see what would work best for that particular patient. But I definitely recognize those are extremely difficult cases. And I would be happy to sort of talk with you offline if you wanted to discuss specific cases as well. Yeah, I'm not sure if that answered the question, but yeah, certainly challenging.
The difficulty for sure. So I appreciate that.
Absolutely. Let me take a look if it seems like there are some questions here on the chat. Okay, so we have a comment here. Unchanged CIMT is probably actually a marker of safety in this study, despite higher LDL. No worsening in CIMT. Yeah, that's a very good point, Daniel. I think the authors here mentioned, I had a little note here, that they had mentioned that the lack of changes in CIMT in the 2 groups, it could be due to insufficient duration of the study, and variations in imaging and interpretation among the analysts that could have made some changes. And they also noted here that the CIMT analysis did not include carotid plaque assessment, which I'm not sure exactly what that assessment entails, but it seems like there were some gaps in their data collection. All right. Do you, I guess this is a question from me, but do you all enjoy having literature reviews like this in our Q&A sessions? Because if so, I'm happy to incorporate, 10, 15 minutes of some sort of study that's up and coming in our future Q&A sessions going forward. So we have a comment from Dina here. She says, in my experience, patients tend to experience improvements in GI symptoms with carb restriction. If they're having symptoms on their current diet, it's worth a try of low or very low carb. So that's a really great point. It seems that in her experience, she's seen improvements in GI symptoms. So perhaps Ankur, maybe sort of going off of that, taking a look, recalculating their current baseline carbohydrate intake and seeing if patients are open to trying, making sure that they're consistent with their carb goals, or even, to see if they're consistent with their carb goals, and even going a little further if they would try to, if they would be open to giving that a go. All right. Okay, it looks like some of you are interested in having some literature reviews, so I'll definitely keep that in mind. This time I didn't receive any pre-submitted questions, so for next month, if any of you have questions that you wanted us to discuss during these talks, feel free to submit those prior to our Q&A session, and I'll be happy to walk through them with you all. All right, I'm going to stop sharing now.